Alright guys, let's get busy talking about our disorders of sexual development part 2. This is going to be very similar to part 1 in our discussion. We're going to be talking about all these round bullet points, which is going to be the pathophysiology of the disease processes. And then in these square bullet points, we're going to discuss why these phenotypic results occur. So we're going to be using our master diagram, which you guys are becoming good friends with at this point, to explain all of these changes. So go ahead and stay tuned and let's get busy. Let's start off by talking about placental aromatase deficiency, and this is exactly what it sounds like. We are lacking the enzyme aromatase. This is going to be an autosomal recessive condition in which our aromatase enzyme is absent. So let's go ahead and refresh ourselves as where aromatase exists in our overarching diagram. So you'll see aromatase is here, which I am highlighting in brown, and its job is to convert androgens into estrogens in the developing fetus. And this is going to be an important function because we produce some degree of androgens, and there's an important balance between estrogen and androgens, and we need to make sure that balance is staying intact. However, if this aromatase enzyme is absent, we are going to get increased levels of androgens, and at the same time we will be getting decreased levels of estrogen because there is no androgens being converted to estrogens. They are just all staying as androgens. So that's the basic pathophysiology of what happens here. It's pretty simple right down there in the bottom corner of the diagram. So let's review. It's the inability to convert androgens into estrogens, so we're going to get increased androgens. Now, what happens when we have increased androgens? We know that androgens are responsible for masculinization in terms of the developing fetus and also during puberty, and so we're going to get fetal masculinization. So let's talk about what happens when we have fetal masculinization. So we know in our review from previous videos that estrogen is responsible for the female development of the external genitalia. And we also know that it was DHT, which is a very potent androgen that is responsible for the external male genitalia. So you're going to see we have a fundamental imbalance here. We have increase in this andronergic activity, and we have a decrease in this estronergic activity. So we're going to get very significant masculinization of this fetus's external genitalia. And in most cases, in most question vignettes, they're going to give you a newborn with an XX genotype. And this is important because this XX genotype we would expect to have female external genitalia. However, this XX genotype baby is going to have masculinization or perhaps ambiguous genitalia, and that's going to lead to a workup. And so this workup is going to involve some further questioning. One part of these questions that really pops out is they will usually mention mom. And so the increased androgens in the fetus actually are going to spill over into the mother. And so you're going to get maternal masculinization as well. So mom will present with things like acne and facial hair and maybe deepening of the voice, and then our infant is going to have the ambiguous genitalia like we previously talked about. Additionally, as this child grows up, they're still not going to have aromatase, so they're still going to have that fundamental imbalance of androgens and estrogens, and this is going to lead to them having primary amenorrhea. Because let's do a review of what we need estrogen for. We know that we have low estrogen in these patients, so they're going to be unable to do all the things that estrogen is normally responsible for. So they're going to have no breast development, they're going to have absence of normal female fat patterns, so they may have like a very skinny build without female appearing hips, and they're also going to be unable to carry out menses. In terms of our lab values, we're going to expect to see decreased estrogen and increased testosterone, and this makes sense if we think about the fundamental imbalance that's occurring here because of our lack of aromatase. Now, I want to do some important differential building for you guys here because there are other conditions in which we get masculinization of the infant, and one that's important to talk about is congenital adrenal hyperplasia. Now, this is a variety of disease processes which we're not going to get deep into, but essentially there is faulty shunting of steroid precursors. So we know that steroid precursors go on to make a variety of molecules. Some that we want to mention are things like androgens and estrogens and aldosterone and cortisol. And so what happens is we can get differential shunting of these molecules in congenital adrenal hyperplasia. One specifically is called 21 alpha hydroxylase deficiency, and this is going to cause an increase in androgens because basically these steroid precursors are being pushed more towards androgens than other things. And so in these patients we're going to see an increase in androgens, which can cause similar masculinization features. However, in congenital adrenal hyperplasia with 21 alpha hydroxylase deficiency, we would also also expect to see decreased aldosterone because of the abnormal shunting, which would cause decrease in blood pressure and increase in potassium, and we would also expect to see decreases in cortisol. And this is a great way to separate it from aromatase deficiency, which is only going to show the masculinization features without those additional blood pressure, potassium, cortisol findings. Let's move on now to talk about K.A.N syndrome, which is going to be another disorder of sexual development. And in K.A.N syndrome, it's all going to be about our GnRH neurons and their failure to migrate to the hypothalamus. So if we do a little bit of drawing here in our master diagram, I'm going to outline our hypothalamus right here. And this is going to be in close connection with the pituitary gland. And it also happens to be really close to our nasal structures. So I'm going to go ahead and draw in a nose here as well to show you guys that this is very close to where our nose would be. And sorry for my drawings, they are a little bit shoddy, but you guys get the picture here. And there's some important structures that I want to add into our diagram here, namely the olfactory bulb. So here's going to be our olfactory bulb, and what it does is it is responsible for a lot of our sensation of smell. Now, interestingly, there are GnRH neurons, and so these neurons are going to be responsible for gonadotropic activity. And normally these neurons take a nice little path from the olfactory bulb into an area called the preoptic nucleus that exists in the hypothalamus. So let's just review that pathway here. We go from olfactory bulb to the preoptic nucleus, and essentially what happens here is this migration is failing to happen in these patients. So this pathway somehow gets interrupted and we get that failure of migration of GnRH neurons. These GnRH neurons are important because they're going to be responsible for a lot of gonadotropic activity. So we have failure to stimulate gonadotropic hormones. Essentially, the hypothalamus will not be releasing any GnRH, or if it's releasing some, it will be very small amounts. And we like to call this hypogonadotropic hypogonadism. And we talked about hypergonadotropic hypogonadism in our cases of Klinefelter's and Turner syndrome. This is different. In these cases, we do not have very many gonadotropins at all, which is why this is considered hypogonadotropic. And so our gonads are actually operating just fine. So you'll remember our gonads, which were our gamete makers, our testes, and our ovaries. In K.A.N syndrome, there's essentially nothing wrong with them. It's failure up here in the axis of the pituitary and the hypothalamus, and their inability to produce gonadotropins because we had that abnormal migration. So if we were to look at our labs here of a hypogonadotropic hypogonadism, we would expect to see decreased GnRH. This is our primary insult. We cannot make GnRH in the hypothalamus because we had failure of those neuron migrations. So that's going to lead to decreased FSH, decreased LH, and therefore that's going to cause decreased testosterone and decreased estrogen. And this is going to be the classic lab values for a hypogonadotropic hypogonadism. So let's talk about how this is going to present based on the pathophysiology we just discussed. We're going to have lack of secondary sex characteristics in these patients, and this makes sense, right? Because at the end of our pathway here, we have decreased testosterone and decreased estrogen, and we know that those are important for development of these secondary sex characteristics. Next on our list is going to be primary amenorrhea, and this also makes sense because we know that estrogen is going to be necessary for menses. We talked about that up here when we were talking about aromatase deficiency, and so the same physiology is going to apply to K.A.N syndrome. Next on our list, we have decreased sperm count, and this also tracks because we know that sperm maturation and sperm production is going to be heavily dependent on levels of testosterone, which in this condition are low. So let's talk about cryptorchidism. In previous videos, we discussed how the path of the testes from the retroperitoneal space down into the scrotum is heavily dependent on testosterone. We have low testosterone in this condition, and so that migration is going to get interrupted. We can get cryptorchid testes here, and these need to be manually placed back in the scrotum with orchiopexy in order to prevent testicular cancer. Next, let's talk about the fact that these patients are going to have decreases in height, and this makes sense because when we don't have release of FSH and LH, it's like we never even went through puberty, and we know that puberty is an important time for growth, and so these patients, especially our male patients, are going to present with decreased height. So I want to make a note here that this is usually going to be in male patients where we see this because the male height development is heavily dependent on testosterone. And lastly, the most interesting finding here is going to be anosmia. And for those of you that don't know what anosmia is, It stands for lack of smell. And these patients are going to have lack of smell because it goes back to our discussion from our master diagram. So remember my really bad drawing of a nose here that you guys are probably laughing at? Well, that relates to why they have anosmia. So we talked about this red olfactory bulb, right? And that's where our GnRH neurons were supposed to migrate to the preoptic nucleus in the hypothalamus. Well, that's not the only thing that goes awry here. There are special neurons responsible for our sense of smell that also undergo some complex migration in this area, and that migration fails, and therefore these patients are going to have a really reduced or sometimes a lack of smell. And I cannot stress enough how high yield this is, because you're going to get someone on exam day who maybe doesn't have periods or who has lack of secondary sex characteristics, and they report that they have difficulty smelling, and you're like, oh my gosh, this sounds like K.A.N syndrome, and then you can easily get that diagnosis right, and this will literally jump off the page at you guys. So let's wrap up with a high yield review here. When it comes to placental aromatase deficiency, it's going to be all about that combination of the fetal and maternal masculinization and relating this to the fact that they are lacking aromatase. We will not expect any of the additional findings of a congenital adrenal hyperplasia, so that's a great way to form differential here. On labs, we're going to expect decreased estrogen and increased testosterone. Moving on to K.A.N syndrome, it's all about this fancy migration in the axis of our nose, hypothalamus and pituitary. That migration fails. I would say it's important to know that's olfactory bulb and preoptic nucleus. Those tend to be hot words on exam day. We went through a lot of the findings here, and they're all going to be due to decreased levels of testosterone and estrogen. And then most important, be on the lookout for that anosmia, which is lack of smell. This is going to be so high yield in terms of recognizing K.A.N syndrome on exam day. I hope you guys enjoyed this one. Can't wait to see you in the next one.